because it is a public meeting. The recording will be posted on the Commission's webpage shortly after the meeting. TVW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. As a reminder again, if you're not a member of the Commission, please turn off your camera now. Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
Hey, good afternoon. Welcome, Commission members. It's now 2:01, and I call the April 11th meeting of the Universal Healthcare Commission to order. I'll begin with a land acknowledgement and just reminding the rest of the Commission members, if you ever want to do one in my place, I'm happy to let you. So we do land acknowledgements because it's really important to remember not only whose land we are on, but the history of what happened in the United States and then what came of that loss of land. So I have a luxury that not a lot of Native people have, where I actually live on the land of my ancestors up here in Olympic Peninsula. My ancestors are the Jamestown S'Klallam tribe, or the Stititlam-Nuslayim, the Strong people. And I want to thank them and all of our other Salish neighbors for their stewardship of this land and our waterways from time immemorial. So thank you for allowing me to do that. And then I just want to give everybody a warm welcome and thank you for joining us today. This is our 11th meeting of the Universal Health Commission meeting, and we're really getting into the meat of things now. It's very exciting. I'll start with an overview of the agenda. We'll begin with roll call. Mandy will call out our names, and in keeping with our theme, because we're only meeting on Zoom, of trying to get to know each other better, our question this month is, what's your favorite thing to do in spring? So after roll call, then we'll have the meetings, we'll review the meeting summary from February. And then we'll get an update from the FTAC, very exciting. Pam McEwen here is our liaison and will be updating us on the work that they're doing. We'll hear public comments. Then after public comments, we have a request for us to review about the Washington Health Trust Bill, which is Senate Bill 5335 or House Bill 2023 that we received from Senator Cleveland. And then we have Dr. Johnson is going to give us a presentation about equity. And then we'll go to our consultants to continue our work on transitional solutions. Then I encourage each of you to ask questions and provide feedback to both the consultants and Dr. J when we're going through this work, and that is for commission members. And so just a reminder that the meeting, when we have questions, that's for the commissioners, and public comment is for the rest of the people on the call. I know sometimes it gets confusing on Zoom. So I want to thank everybody for being here and for all their efforts. And I'm going to turn it back over to Mandy to do our roll call. And remember, we're answering the question, what's your favorite thing to do in the spring? Thanks, Mandy.
Thank you. Good afternoon, Commission members. I will call members by first name in the order listed in the agenda, which is alphabetical order by first name. When I call on you, please unmute your microphone and let us know that you're here and what's your favorite thing to do in spring. And then please mute your microphone again. Chair Vicki?
I am present, and my favorite thing to do in the spring, we did last weekend before last, is the waking of our canoe. So we did a cleansing ceremony with our tribal canoe, and then we were going to take it out in the water, which is like my next favorite thing to do, except for it started hailing and raining, so we had to do that another day. But getting the canoe out and going in the water is my favorite thing.
Sounds amazing. I also love to be in the water. Senator Ann? Senator Ann? Vidisha?
Hello, I'm here. Let's see, I don't know if I have a specific thing in spring that I absolutely love to do, but I know what I have to do is to get my yard in order after maybe finish the raking from fall semester.
That's great. Thank you. Dave?
Here, I like to see the new spring flowers and especially our cherry blossoms and this cherry tree in our backyard. And stopping checking the legislative website because Ledge will be out of town. That's my other favorite thing to do in spring.
Good call. Senator Emily? Senator Emily? Estelle? Estelle? Jane?
Hello, everybody. I'm assuming all the legislators are either in caucus or on the floor today. It's a busy day. So what I love to do in the spring is to be able to take a walk in the evening without a headlamp. And I will never, ever, I grew up in New York, I will never, ever adapt to the fact that it's not spring here truly until June. So that's my big personal challenge, which I haven't been able to deal with now for 35 years. And I'm going to go off camera for a bit so I can finish my lunch because you guys don't need to see me eating.
Thank you, Jane. I just took a walk and it was hailing while I was out walking, so I understand. Joan? Joan? Representative Joe? Representative Joe? Karen?
Good afternoon, everyone. Dr. J here. Literally just getting back from vacation. I'm absolutely with you, Jane. And Dave, those cherry blossoms are all over my car and I'm enjoying it. But what I really like to do in the spring, other than watch March Madness, is to clean house. To do that deep cleaning, get all the junk from the last season gone, everything set up to bloom and flourish in my life by cleaning my house.
Nice. That sounds very, very good idea. Very well organized. Kristen?
Hi, good afternoon. Well, I try to live in the present, but I have to admit in the spring, I'm already thinking about the summer and the warm, long, sunny days. But I have to agree with Dr. J that I do love to purge and clean house and clean the garage and get things ready so I can play in the summer.
Excellent. Representative Marcus? Representative Marcus? Mohammed?
Thank you, Mandy. Yes. What do I enjoy the most about the spring? I think I would say hiking. Because I don't do that, a lot of that in the winter and fall. So I get back to that and then kind of look forward to the summer. So thank you.
Excellent. Thank you. Nicole?
Hey everyone. Oh gosh. So I would say that in springtime, I have the luxury of being an executive director of a program that allows me to travel this great state. And every spring, I have the opportunity to go to Yakima/Union Gap area, and I did that this past weekend. And what the great thing about that is I get to bring back tamales, Los Hernandez tamales, and I cannot wait to eat those. I'm very excited. They did not have the asparagus ones yet, but I'm looking forward to eating what I got.
Excellent. Thank you. That sounds delicious. Stella? Stella? Thank you, everyone. I'll turn it back over to the Commission Chair, Vicky Lowe, who will facilitate review of the meeting summary and public comments.
Thank you, Mandy and Nicole. I'm really interested in learning more about those asparagus tamales. So if you join me by turning to the second tab in your commission book, or check out on screen here, there was a recording of our last meeting, and we just need to approve the summary. So I'm asking if there's any discussion or any changes made to the summary from our February meeting.
Chair
Okay,
Lowe, I will move to approve the minutes as presented and written.
awesome. Thank you, Dave. We have a
And-
motion.
And I will second.
Thank you, Jane. We have a motion and a second. All those in favor say aye, either raising your hand or unmuting. Aye.
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 Any opposed? All right, motion approved. So next on the agenda, we have Pam McEwen, who's the lead and liaison for the Financial Technical Advisory Committee, here to give us an update. Thank you, Pam, for joining us. Are you there, Pam? I know she was there earlier. Oh, you're muted. Angela, can you unmute her?
Let's see what we can do.
Okay.
Wait, I'm unmuted. I'm unmuted.
There it is.
You don't have to save me, Angela, this time.
We hear you, Pam.
I am dealing with my little screen on my Apple, and sometimes I can't get to the right screen. So here we go. So good afternoon, Chair Lowe and commission members. I'm just going to take a few minutes to bring you up to date on FTAC's second meeting from March. And the meeting summary can be found under tab 3 of your materials. The 3 main topics that we worked on in the last meeting. One was the transitional solutions that you all have been discussing. We did our version of that discussion. We had a presentation by Chair Lowe on the Indian Health Delivery System, and we discussed Medicare eligibility. So I'm going to just kind of take these in order. There was a lot of engagement in the transitional solutions discussion. This is a group of people with a lot of experience in health reform and the difficulty of implementing major reforms. So there was real interest in how we get from here to there and the opportunities that transitional issues can present in building bridges to reform and providing some immediate improvements. I'm not going to go into any details. John Crom's going to be recovering that with you later in this meeting. Chair Lowe's presentation was very much appreciated. She described the Jamestown program's approach to universal health care, including all eligibility groups through wraparounds, which ensures that members experience the same level of benefits regardless of their source of coverage. This was great grounding for our discussion on the options, including to include Medicare enrollees in the universal system. HMA facilitated the Medicare discussion. As the commission is well aware, there is no precedent for a waiver that gives state control over Medicare funds and program administrations. So as a result, there wasn't much energy from the committee on pursuing a waiver at this time. HMA actually noted to us that Congress and CMS would be likely to be more receptive to granting the state authority of Medicare funding and the administration in the future, after the state's able to demonstrate improved equity, quality, and access, and reduce costs through consolidating state-run programs. So to have, have something of a proven track record. The commission also asked FTAC to examine 2 pathways to include Medicare in the universal system. One would be state-run Medicare Advantage plan to cover Medicare non-covered benefits. And the second would be kind of an option to wrap around Medicare benefits. We began the discussion on the pathways. We did not get to a conclusion, but we started, we had a robust discussion at our, and we'll be coming back to this at our May meeting. We're lucky to have Christine Eibner in our group. She's a senior health economist at RAND, and she's going to present and guide our discussion so that we can further flesh out these alternatives that have been identified by the commission to identify pros and cons. The next the major focus of the next meeting will be to solidify our guidance to the commission on the pursuit of a Medicare waiver and hopefully come away with some pros and cons. ERISA recommendations are kind of next up in our work plan. And so I just wanted to note that we would appreciate any and all guidance from the commission members on this important and very complicated topic. And thank you. Hope to bring back more on FTAC's Medicare guidance at your June meeting. Any questions for me?
So I guess I have a process question, Mandy and Vicky, in terms of seeking guidance from the commission on ERISA. Do we have when would be the time to do that?
We have a discussion set up for that. It's during today's meeting.
Perfect. Thank you.
Not a problem at all. And of course, if you think of something afterwards, feel free to email me and I can include that into the tech questions.
Are there any other questions for Pam? I participated in the meeting and it was just the conversation was just fabulous. So very excited to see further work of the FTAC. And Pam, I just really, again, want to thank you so much. I know you just retired and we roped you into doing this work. So I really appreciate you devoting time to this.
So far, it's been great. Thanks, Vicki.
Thank you. All right. We have public comments received since the last meeting are found under tab 4. We're opening up the floor for the comments. We allowed people to sign up before the meeting, and we'll start with those who have signed up first. If you've not signed up and would like to provide public comment, please raise your hand. Mandy will call on those individuals who've signed up first, then go to the people who have raised their hands. When you're called upon, please state your name and if you have an affiliation, if any, before you speak. If you're unable to raise your hand, then at the end of the comments, we'll open it up to everyone else. There are a lot of people signed up today, so we're given 60 seconds. And I hope you received that notice that was sent. The timer's on there. And if you don't have enough time to get your full thought through, please think about sending us written comments. Sorry. And so, Mandy, do you want to start with the individuals who signed up?
So, well, thank you, Vicki. I have Zach O'Brien. Zach. I'll move to the next name. And then if you happen to join later, just let me know. Ben Kilfoyle.
Oh, there we go. Can you hear me okay?
I can, thank you.
Hi. All right. Hi, I'm Ben Kilfoyle, he, him. And I just moved to Washington and Olympia from Oregon about a year and a half ago. Really loved it up here. Actually bought our first place, our first home in Olympia. And I just want to talk about my medical journey. So I used to get a medication called mesalamine. The reason I need this is for ulcerative colitis. Essentially, I have bleeding in my gut that I need an anti-inflammatory for. On insurance, that cost me $15 per a 3-month refill. Off insurance, it cost me $400. I've looked on pharmacychecker.com. I've talked around with some of my friends who work internationally, and they say the tablets, they can find them in their local stores for 27 cents a tablet. That comes out to about 80 bucks for a 3-month refill. All this math to basically say that if I don't want to poop blood, I have to be insured. And I recently lost my job. I thank God that I have a partner who is insured, but if I didn't have that, I would go broke buying really basic medication that costs pennies to refill, to create.
Thank you. Mike Benefield.
Yes, I'm Mike Benefield. And our current healthcare system allows insurers to override the treatment decisions of our doctors, to use denial of claims, and raise premiums, all to boost their corporate profits at the expense of our welfare. This is monstrous. The whole modern world knows the solution, that we must get the for-profit insurers out of the system. Transition problems can be worked out after we set up the system that will help the millions that need help now. SB 5335 will provide a system that can be implemented that will provide coverage for comprehensive health care free at the point of service, no deductibles, no coinsurance, no premiums. This can be done while we're working on getting the federal waivers. There is no excuse to continue our system that puts profits ahead of the lives of our loved ones. Thank you very much.
Thank you. Nancy, and I'm sorry, Nancy, Bosflug?
Bosflug, yes. So I'm Nancy Bosflug. I live in Newcastle. I'm a PCO with the 41st. I live in Newcastle now, but for 20 years, I raised my family in France. And my reason for testifying today is just to tell you that the French health system works. It works for young kids. It works for my older family members. It works for visiting friends. It works for expat Americans. The French are proud of their system because it works for everybody. I also lived in England for 5 years. They have a very different system. It also works. You know this because you've done all the work and you've seen the countless work done by others over decades. And you know that we need it in Washington. Any of the 3 models that you've suggested will improve on what we have. It appears to me that you have all the information you could possibly need, but what's required now is the political will to champion it to the legislature. Thank you.
Thank you. Elizabeth Hovet? Elizabeth?
Hi. Hi, I'm Elizabeth Hovde from the Washington Policy Center. Thanks for your time. I've also submitted longer written comments for you. Government provided care sounds good until it doesn't, even before you get to the insurmountable cost that of other states abandoning their plans. In other experiences with it, we see that affordability, access, and quality don't go together. Socialized healthcare leads to the rationing of care as demand always outstrips supply. We need to be careful what we wish for. As you analyze the failing Senate Bill 5335, please consider problems with the access and quality in other countries. Our third-party payer system is a large part of our problem, separating patients from consumer knowledge. Cost will continue to increase as long as someone else is paying the bills. Another piece of the problem is the verbiage that healthcare is a right. It's not, it's a need, just like other needs that we have and must prioritize. State health care solutions don't have to be between the system we have now and socialized care, and I'm happy to help with other ideas for cost containment and point you to free market solutions. Thanks.
Thank you. Chris Curry?
Chris Curry, retired RN, Spokane. I just want to highlight my summary of the 4 options for dealing with Medicare that is included in this month's, at the end of this month's meeting materials. Full integration needs to be the goal in order to both save enough money through simplification and generate enough revenue to fully fund the universal system. Therefore, please make writing the UHC bill and the 10-year budget your highest priorities so that the 1332 waiver application can be submitted as soon as possible. All of the necessary pieces are laid out in the Washington Health Securities Trust bill. Time is of the essence. Thank you.
Thank you. Noah Peterson?
Hi, my name is Noah Peterson. I'm 22 years old and I live in Olympia. I strongly support Senate Bill 5335 for universal health care in Washington. With families choosing between food and medicine, people using expired insulin, a mental health crisis, increasing predatory price gouging on medicine, and debt from emergency room visits, among other issues, it's clear that our healthcare system is in a sorry state. Many people avoid seeking care for illness because they know they cannot afford it. This has led to needless suffering for residents of Washington and many other states nationwide. Your 2022 report showed that universal health care would lead to significant economic savings. Please analyze this bill swiftly so we can set an example for other states and provide much needed relief to our residents. Thank you.
Thank you. Elmore?
Hi.
Hello.
I'm Warren
Elmore?
George. I'm Warren
Elmore?
George. Can you hear me?
No, I'm sorry. It's Elmore Street.
Yeah, I'm here. I'm here. Yes. Yes, I am Elmore. I'm a transgender student on his parents' insurance for only a couple more years, and I worry that after that safety net is gone, if I can cover the hormones I rely on, my wisdom teeth that need to be removed, or an emergency that might happen, and my worries are not unfounded. According to a report done by the Families USA Foundation, in this country, 1 in 3 of all COVID deaths were linked to insurance gaps, making 1 in 3 of the million lives we lost victims of private healthcare. We are one of the only industrialized nations that does this, and our citizens are the casualties of that choice. We need change now, and we need to make the Washington Health Trust a reality. Thank you for your time.
Thank you. Judy Damore. Judy?
Hi. Yeah, I'm Judy Damore. I'm in Port Townsend. Can you hear me?
Yes, I can. Thank you.
Good. Thanks for letting me speak to you. Clearly, we need to address the health needs of people who have no health insurance at all, but I want to speak about those who are supposedly insured but are not able to address essential health care. My 45-year-old son, who's employed by a local business, doesn't get health care through his work. The only policy he can afford has a $5,000 deductible, and many of my self-employed friends are in the same situation. My son never sees a doctor, even for complications he's had from COVID and other viral illnesses this year, because he's afraid of what it could cost him. Extreme financial barriers at the point of service are leaving people like my son without preventative care or diagnostic testing to detect conditions that may become life-threatening if left untreated. This is a public health crisis for low-income people, especially those not insured through employment. Please adopt Model A and help get it implemented as quickly as possible. Thank you.
Thank you. Catherine Lewandowski. Catherine?
Hi, can you hear me?
I can, thank you.
Okay, hello, for the record, my name is Catherine Lewandowski. I'm a registered nurse working in Washington State for 37 years. I want to make a couple comments on Dr. Stephen Kempo's slides that I shared with all of you. On slide 23, he discusses that all the evidence shows overutilization is not the problem in America. And in fact, it is Americans' inadequate access to appropriate care that is a huge driver of inflated costs. This is what I've witnessed throughout my career. Most Americans don't like going to the doctor, but when they are afraid to go to the doctor because they fear what that cost will be, they tend to wait too long and the problem has escalated. This leads to the illness being more costly to treat and often to the treatment being unsuccessful. And on slide 28, please note what Connecticut was able to save by unprivatizing their Medicaid program in 2012. Where between 2008 and 2012, the cost for their program rose 45%. They elected to become self-insured and also enhanced their support for primary care. This increased the number of doctors who accepted Medicaid patients, reduced ER usage by 25%, and reduced hospital admissions and readmissions by 6%. 6 years later, they had reduced their Medicaid costs 14%, all by just unprivatizing. Thank you.
Thank you. Maria Elena Van Gever. Maria Elena?
Is it okay if I listen to?
Hi, sorry, I'm just trying to figure out.
Yeah,
My name's, can you hear me?
I can, thank you.
Okay, my name is Maria Elena. I'm a family nurse practitioner with Seymour Community Health Clinic. At our clinic, we
All right, just returning. Maria Elena?
Yeah, should I keep going?
Yes, please.
Okay. At our clinic, we care for a diverse group of people, low income, people working multiple jobs, working poor, many people of color, immigrant, refugee, and undocumented community members. We see patients of all insurances, many who have none, who can't afford it or simply can't qualify for the options in our state. I see daily how our current piecemeal system hurts people, puts up frustrating and unnecessary barriers, and burns out healthcare workers. and requires that I know workarounds and put in extra unpaid hours to try to meet my patients' unique situations, helping them navigate our messy, broken system. Daily and weekly, I manage frustration and heartbreak over why does it have to be this way and what are we going to do? We need change urgently. We need a comprehensive, publicly funded system with no financial barriers to getting care, treatments, and medicines for everyone. I ask that you urgently all work to recommend a clear path to Model A system, truly universal and accessible option, something like SB 5335, the Washington State Trust Bill.
Thank you. David Satgast?
Sorry about that. Give me a sec. I'm ready.
Oh. Okay, David, go ahead.
My name is David Satgat. I'm 32 years old. I live in Shelton, Washington. I have autism spectrum disorder, depression, and bipolar. I currently live with my parents, and I've lived with them since 2012. My father is John Satgast. As you may know, my father is a writer for the Republican Party. I'm stuck in my parents' home due to the sheer cost of my medical needs. I cannot live independently of my parents' insurance coverage. I deeply care about mental health, which would be covered by good universal health care plan. With such a plan, I and many others in similar situations would be able to live much happier lives independently without the fear of spiraling into debt. Thank you for your time, and please consider the people who are so severely affected by this.
Thank you. And as a reminder, just if everyone has any background noise or they haven't muted your microphone, will you please mute your microphone now? Andrew Smith? Andrew Smith? Okay, Connor Buchanan? Connor Buchanan?
Hi, can you guys hear me fine?
Yes, I can, thank you.
Absolutely. Hello, my name is Connor Buchanan, age 25 from Puyallup, Washington, and I support the move for universal healthcare. I cannot afford healthcare without my job, but more importantly are my grandmothers who served in the community but country who cannot afford to die in this country. Frances Aiken at the age of 64 cannot afford to work without losing her benefits, but also cannot afford to not work due to the cost of living, even with her Social Security as her disease worsens. Betty Knox at the age of 94, who is a decorated service member to not only our country, but our communities, cannot afford to die without losing her savings to care or force her children to watch as disease takes not only her body, but her mind as well, causing her children to be traumatized just as she was by her mother. This is unconscionable for not only myself, but for the old who are forced to make these decisions at the end of their lives, which is supposed to be a time of peace for veterans and their families with a legacy of serving our government. Thank you for your time.
Thank you. Maureen Brinklund?
Yes, good afternoon. Thank you. My name is Maureen Brinkland. Can you hear me?
Yes, I can. Thank you.
Oh, okay, great. And I live in Ballard. My name is Maureen Brinkland. I'm a PCO in the 36th district. I'm also a first generation child immigrant from Norway and Ireland. All of my first cousins have lived in countries where they never had to worry about healthcare costs that would drive them into a bankruptcy. I'm interested in the commission's work, and I thank you very much for this very hard job you're doing. And I'm just concerned that perhaps the single payer part of the law stipulation in the bill that created the law 5399 is being given maybe a short shrift. I don't see anything in your vision statement having to do with single payer, but it is in the law. And I just hope that the commission would please instruct the FTAC to explore a single payer option as it's required in the law. Thank you very much.
And just as a reminder, we do have a lot of meeting attendees today, so will you please mute your microphones?
Hello, can you hear me?
Yes, I can. Thank you.
Okay, so my name is Marcia Stedman. I'm a volunteer with Healthcare for All Washington, and I'm here commenting on their behalf and as well as my own. Shut up. And I would like to talk about ERISA a bit because it's on the agenda today. It's common knowledge among health policy experts that states have no authority or control over ERISA. These are employer-regulated health benefit plans that are offered by employers to their employees. So I'm mystified as to why the Commission's work plan devotes portions of 4 meetings to this topic, from today and then from July through October. The best way to deal with ERISA is to set it aside for now and spend the time designing a health plan that will provide access to care for the thousands of Washington residents who do not now have access. Thank you.
Thank you. Trocita Lopez?
Was that Joselito Lopez?
Yes, please. Thank you.
Okay. Good afternoon, commissioners. My name is Joselito Lopez. I'm a patient from Snohomish County and a member of Washington Can Community Action Network. 9 years ago, I suffered multiple heart attacks, 2 heart attacks, and a double bypass. After losing my employer-sponsored insurance, I had tens of thousands of medical debt that led to bankruptcy. I knew what it's like to be an Apple Health patient with no one accepting my insurance. And my story is one of thousands of patients. We do not have to reinvent the wheel. Advocates have been working on this issue for years. The idea for a Washington Health Trust provides a good starting point. We can also take lessons learned from Oregon, which is setting up its own single-player system as we speak. If they can do it, so can we. With our lives on the line, we cannot afford to wait. All patients, but in particular, immigrants and refugees and Black and Brown communities across our state will be severely impacted. The longer this process takes, an essential first step in the journey is knowing where we are going together. Thank you.
Thank you. Jen Nye?
Thank you. My name is Jen Nye and I live in West Seattle. And while I'm grateful the Commission is working on a plan for more affordable and more patient-centric care, I'm very concerned that these terms are nebulous and that they mean different things to different people. What's affordable to one person can be completely out of reach to another, and circumstances can change month to month. The most humane thing we can do is to demand no out-of-pocket costs, no copays, no deductibles, and no medical bills whatsoever. These costs are manufactured by insurance companies to deter people from seeking care. And I'm living that experience right now. We had a car repair, a vet bill, and I'm extremely concerned what my labs will cost. My insurance only pays a percentage, and I've spent weeks trying to get a benefit quote. If this is what the Washington Policy Center refers to as being an educated consumer, I say no thank you. We have to remove these hoops and financial barriers for everyone, so please define these goals. Thank you so much.
Warren George?
Thank you. My name is Warren George. I was a governor-appointed member of the Oregon Task Force on Universal Health Care. I'm here because I'm following closely the developments in Washington because I see great advantages in a regionally coordinated approach to universal care. Today, I'm simply notifying testimony in support of, I'm supporting testimony, single payer. I've heard discussions about public options, and certainly our evidence in Oregon is they don't go far enough to deal with the problems that a single payer system can achieve. And I'm just hoping that the Commission will be open to that evidence. Thank you.
Thank you. Consuelo Echeverria?
I can, there I am. Sorry about that. Consuelo Echeverria from Healthcare for All Washington, and I, along with my friend and colleague, Marcia, would like to also suggest that instead of focusing on ERISA, that if the commission shouldn't consider how to consolidate and unify the financing and management of the PEB, SEB, Medicare, along with other state-based exchange programs as an interim step towards universal health care. And finally, in terms of ERISA, I would like to just suggest that perhaps the commission can look at the Oregon Task Force and their ruling, which has a very, I'm sorry, I didn't prepare these comments, which has a very complete ruling on recommendations of how to deal with ERISA. And that's in the Oregon Task Force report.
Thank you. And that is everybody that has signed up for public comments. I will turn now to any raised hands for public comments.
I'm Sarah Weinberg. And my hand is raised. Okay.
Sarah.
Thank you. As a retired pediatrician, I remember the days when seeing and billing for office visits for children covered by Medicaid was easy. My office staff submitted the claim to the Department of Social and Health Services, and without a huge delay or fuss, a check came back to pay me. This was helpful since my practice was 25% Medicaid. Then in 1990 came the Healthy Options Program, which was a big administrative hassle. I won't bore you with the details of how it upended my office's billing process, but it ended up costing me more administrative expenses and less take-home pay. One useful step that our state could take toward universal unified healthcare system would be to take Medicaid back from the private insurers and have the healthcare authority run it. Connecticut did this in 2012, and it's working for them.
Thank you. Vicki, I want to check in with you. I know that we're over the time for public comments, and I see 6 hands raised. Would you like me to ask folks to submit it in writing, or where would you like to call this at for public comments? Continue, or?
Yeah, let's continue and get the last 6 in. I think we can still get through our meeting.
Okay, sounds great. Thank you. I see Zenthia. Okay, I see Emma.
Zenthia's getting to you.
Sorry?
My sources indicate Zenthia's getting tea at the moment.
Okay, Emma?
Hi there. My name is Emma Devereaux. I'm 27. I live in Concrete, Washington. Private profit-driven health insurance is ballooning the cost of healthcare in America. We spend almost double what most other G20 countries do on healthcare, yet we rank 35 on the healthcare index. Many families cannot afford the draconian premiums and deductibles, and when a common medical emergency happens, they are still left to deal with a bill worth tens of thousands of dollars that would cost hundreds in a single-payer system. In 2023, 6 out of 10 Americans do not have $500 in savings. A medical emergency would make them homeless. Healthcare is an inelastic market because the sick and dying have no choice to refuse a service. A universal healthcare system would drastically reduce privatized markups on treatment and medication and allow for a robust infrastructure that is easily regulated for quality and ethical outcomes. Socialized healthcare can also prioritize preventative medicine, which research shows would save the taxpayers billions. Thank you.
Thank you. I see Ronnie Scher.
Thank you. My name is Ronnie Shore. I'm the president of Healthcare for All Washington, an advocacy group here in our state. And I'm disturbed to hear someone call a single payer healthcare system socialized medicine. We're talking about socialized insurance, just like we have for firefighters, for police, for school. And so I just wanted to establish that point. So thanks for the opportunity to step in.
Thank you. Mason? Mason 23, am I?
Yes, hello there. My name is Mason Chittick. I live in Michigan, and I would just like to say that me and my brother growing up, we were born with epilepsy and seizures, and our parents could barely afford those costs to medicine, plus all the other expenses like MRIs and that. And I would just like to say universal healthcare would have helped us so much growing up. And this is a really important topic to me. And that's all I really have to say. Thank you for your time.
Thank you. Laura Downey? Laura? Gareth Moorish?
Hello, can you hear me?
Yes, I can. Thank you.
Hey, I would just like to say, as someone who's lived in New Zealand for a while, and recently returned, we have a form of healthcare where if you're not insured, the government will subsidize the cost of medicine for you and basically anyone. If you need prescription medication, it's never more than $5 at your local pharmacy for up to 3 months medication. Doesn't really matter what it is. It's just covered. And New Zealand's a pretty small country. I don't think it breaks the bank or anything. I don't know what that woman from the Washington Policy Center was talking about. It's not expensive. It's not something that's even, on the table for cutting in New Zealand. Anyway, that's my 2 cents.
Thank you. Linda Orgel?
Yes, thank you. I am a strong supporter of single payer universal health care, but I am concerned that you are considering Medicare Advantage as a way to deal with I am on Medicare. Medicare Advantage is private industry. It should not be considered in anything that has to do with universal health care. That is private insurance. It shouldn't have the name Medicare on it. So please, please do not consider Medicare Advantage as an alternative for those of us on Medicare. Thank you.
Vicki, I just want to let you know I had 5 more folks raise their hands afterwards. So after you gave the note, so just wanted to check in with you. Am I okay to continue calling on folks?
I feel like we need to move on to our meeting materials. And so I just want to apologize to those of you who are still have your hands raised, but would you please put your comments in writing and send them to us? And Mandy or Angela, can you put the email in the chat box, or can we do that? Is there a chat box?
I think we can actually do that.
Okay, thank you.
It's also on the notice, by the way, Vicki. It's the web address and the email address are also on the public notice that went out and on the web page as well.
Yeah, so I apologize. I know we've got to get through the request about the trust bill, and then Dr. J has put together a training for us on equity. So we need to get to those things. And so I apologize. But I appreciate so many people wanted to comment. That's really important. Thank you. So we're closing the public comments for now. Again, if you didn't get a chance to speak, please send your comments in writing to us. And then if you can go to your tab number 5 in your materials, we'll walk through the request. And so I think John and Gary, you guys are going to start out kind of giving us some background, and then we'll talk about what the request was about the Washington trust bill. Thank you. John?
Gary?
Great, thanks so much.
Okay.
Good afternoon, commissioners and Chair Lowe. So I will very briefly just review where we are in our work plan, and then Chair Lowe, I will hand it right back to you to talk through the request and get to the vote. So if you could move to the next slide here, very briefly. I'll just note a couple of the changes to the work plan. So you know, as we discussed in the agenda, this month we're focused on you know, getting an update on transitional solutions. We also got a little bit of an update also from Pam on the work of the FTAC. The FTAC will then continue its work to finalize some recommendations around Medicare, and will, following this meeting, start the work of taking up ERISA, and then we'll come back in June to finalize some items regarding the transitional recommendations as well as Medicare options. And then continue the conversation on ERISA. If you can move to the next slide. There haven't been that many changes on the back end of the year on the work plan. You know, only noting that the next conversation may result in some modifications to the work plan, but that will be reflected in our next meeting. So let me pause there. Any quick questions before we move to the main topic for the intro here? Okay, great. Okay, Chair Lowe, I will turn it back to you.
Thank you, John. So I think everyone received the request from Senator Cleveland and hca.wa on looking at the Washington Health Trust Bill, Senate Bill 5335 or House Bill 2023, is that right? And what we could do to work together. And again, you know, here we are, all these people in support of universal health care, so we should really be working together. We got some other people to convince to come on over to join this work. So what the proposal is that the commission analysis should be shared in a report by June 30th, 2024. So it gives us a year. We need to assess whether the proposal aligns with the goals and planned activities of the commission, and John just shared those, and assess how the commission might recommend implementing the proposal. And if the commission considers it within their mission a viable proposal. Need to identify opportunities for proponents of the proposal to thanks a lot, John, substantively engage with the commission in the future, and then engage the leadership of Washington throughout the analysis process and report preparation. And then, so that's kind of what is on the table. And then if you go to the next slide, how HMA can help us, outline the options, the questions to consider for incorporating this work, the analysis, into our current work plan, what John just shared, is how could the commission structure its analysis to be completed in time and in a way that aligns with the commission work. So we don't want to stop what we're doing and do analysis. We want to like incorporate it in there so we keep moving, because we took a substantial amount of time to get the legislative report last year, and we're finally, you know, moving ahead. So how could the commission best engage the leaders of whole Washington through the analysis process and report preparation? And then what are other things that you all think we need to consider? So are there any questions about the request or how we can move this work forward together? And any thoughts on those questions on the screen?
Mohammed?
Thank you, Chair Low. I just wanted to add, is it possible to get some sort of presentation or condensed, summarized, analysis of this from, hca.wa and I forgot the other senator's name. But is that an option? If that would be an option, it would be great to add them to our next meeting. I also think it would be great. There's a lot of work ahead, and I think if we kind of divide ourselves into committees to analyze this, it might work to our best advantage. From what we heard from Oregon, I think committees would be better moving forward. Thank you.
Thank you, Mohammed. So Mohammed is suggesting that a committee take on this work.
Lou, I could be of assistance.
Yes, thank you.
So we do have intentions to build those into the plans, Mohammed. So you'll see the next slide is a motion to vote on whether it's okay for HMA and HCA to develop some proposed work plans for the commission's consideration on how we would incorporate this work. The first part that we have is giving you a summary or presentation related to the bill. So that will be a part of that. It's not a part of the proposal in the slide, but we have incorporated that into our preliminary work on that topic. Does that help? Thank you.
It does. Thank you, Mandy.
Nicole?
Yeah, I was just going to say, I agree with Mohammed. I mean, it's what we've done with some of the other proposals that we've looked at, and to have some people who've been working on those proposals come in and give a presentation to the group so that we're aware of where it started, where it's been, and where it is now. And I think that will help us move forward with next steps. And I also agree that HMA would be a good idea to help us wrap our brains around that content.
Yeah. Thank you, Nicole. Any other thoughts?
I was going to hold off until, because Mandy or Vicky, one of you cued like what's on the next slide. So I was going to hold off comments until I saw what was on.
Go ahead.
Okay. So this is, I think that the idea of integrating this into our current work plan makes sense. And as part of the summary document, it would be really nice to sort of have a sense of, okay, just to remind us, refresh us, right? What elements of a universal healthcare system does 5399 direct us to look at? How does that align or not align with the elements in 5335? And just so that we have a sense of where an analysis would be looking at something other than what we already have on our plate and the resources that it would take to do that. So that we just really understand where it slots in to the work that we've already been tasked to do, and or work that's already been done, given, as Nicole indicated, the information that's already been presented to the commission, like from the Universal Healthcare Work Group.
Mm-hmm. Yeah, and Mandy or John, help me out here. So I think we looked at like the different buckets, for lack of a better word, of work that we're doing and trying to align parts of the bill with those buckets and kind of doing that comparison there, if that makes sense, rather than trying to, eat the whole elephant, just take a bite and fit it into our timeline of what we're already doing.
Yep.
But I'm hearing you that a crosswalk would be helpful.
It would be nice because, I mean, I'm right as a former legislative staffer and dealing with the legislature frequently now, right? I think it's a matter of showing that we're being responsive to the request by showing where the elements of the bill align with analysis that we're already tasked with doing. And then helping Senator Hoskauer and Senator Cleveland understand where there are elements of 5335 that would be totally new to the commission in terms of time, resources, analysis. Because I think in a situation like this, my theory with stuff like this is no surprises. So be transparent, right? So that there's an understanding and there aren't unrealistic expectations.
Thank you, Jane.
Makes sense, Jane.
And again, they didn't offer us any more money or staff when they sent this to us. And that's important to note. I know that there's been some other work, but that is also an issue to consider.
And I think the way to frame up that discussion is to note where there are elements that are beyond the work that we already anticipated doing.
I like that.
Thank you, Jane. I like that too. Good idea.
All right. Any other thoughts or comments?
I agree with all these comments. I think that's great. The crosswalk, seeing how it fits into the work plan. If possible, to get a presentation from the proponents, engage them in that respect so we understand the intent. I was curious about the report date. Did I hear you correctly that that does align, the request for a report in 2024 that does align with our current work plan? Because I didn't see our plan going out that far.
No, it doesn't necessarily align with our current work plan. It's just a request to get that report by that date. Our ongoing work is extended for the life of the commission. So our plan that we have for the commission is just yearly based, and the commission's only mapped out the upcoming year. So this would be projecting into the future past what the commission has mapped out for the upcoming year.
Got it. Thanks, Mandy.
Sure, happy to help.
When is our next report due?
December 1, that's this year, and annually every year after.
And we don't expect the report to be as much as it's an update to what we already did. We did the baseline and now we're updating every year. So we don't expect to have to put as much time into the report. And, we really want to focus on the work of figuring everything out. Okay. So I am looking for a motion. If it makes sense to incorporate the requests regarding the Washington Health Trust proposal into the commission and the FTAX work plan to the extent possible within the requested timeframe, which June 30th, 2024 is the report.
Can I offer a friendly amendment?
Okay.
Within the requested time frame and available resources.
Okay, I like that.
Thank you.
So we have an amended motion.
I'll second the amended motion.
All right. Any discussion? Any discussion? All right. All those in favor of the amended motion, please say aye or give a thumbs up.
Aye.
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 All the opposed, same sign. Okay, motion carries. So we will work on the incorporation and crosswalk and presentations and working it into what we're doing. And as I said, we'll work, HMA and the Healthcare Authority staff will work to outline the options and then fit it into our current work plan. And like I said, kind of fit it into those buckets that we're already working on. All right. So moving on to tab 6, very excited. Thank you, Dr. J, for agreeing to do a presentation with us. We're really looking forward to it. Are you ready? I don't know, she didn't really need an introduction, she's Dr. J, but it's always great to have our own commission members be able to share their
oh, there we go. Good
knowledge with
afternoon.
us. There you are.
So I'm literally just getting back from some much needed wellness break leave yet today. And so I didn't really prepare, yet as I was listening during public comment, I did put together some slides. And I would like to know, where's the agenda? I have until what, 3:45, is that correct?
Yes, 3:45.
Okay, so it's just a few minutes short. So we're gonna.
Dr. J, please feel free to take the time. The only thing that we should probably discuss, I know that we promised you an hour, so I want to be sure that you have the time. We might be able to wrap things quickly up and just roll over the 4 o'clock hour to just talk about ERISA quickly.
Okay, well, I don't want to take it. Well, I do want to. Can you see my screen?
Yes.
Okay, I've been literally out of the office since March, and this is the first time I've really logged in a minute, so give me a minute. You know, thank you, Vicki and Mandy and all of the public comment, people who spoke during public comment. I am Dr. J, the inaugural director of the Washington State Office of Equity, and my heart was heavy. And yesterday when I was out of town thinking about what I was gonna say today, I was reminded that growing up I grew up in Rochester, New York. We grew up in Rochester, although Dad was one of the first Blacks who worked for Eastman Kodak, we still did not have enough money to go to the dentist, because now I realize that we went to the community dentist. And I had a problem with my teeth as a young adult, well, 20s, whatever that is, a young woman, did not have the money because I was a poor college student at the time. And my best friend took me to the dentist, and the dentist had to rip out all of the fillings that were put in my mouth as a child because of, I don't know, mercury or whatever. I don't even remember now, it's been so long ago. And then I made the mistake of turning on the television yesterday, and I tell you, just about every commercial was, I don't know, diabetes medicine, AC1, psoriasis, I'm like, excuse me, what happened to soap opera? Well, I guess I wasn't watching soap operas, but what happened to the days when there were other things that were advertised other than sickness, illness, medicine? Really? No wonder we're sick. I had to turn the television off. I was getting sick just thinking about sickness. And when I was thinking about what Mandy asked me to chat about today, you know, what health equity should look like if we really are going to have equity for all people. And by the way, and when redesigning a healthcare system to be equitable, what are some of the considerations that we might want to be mindful of? And I thought this could take a minute or two. I thought I could probably do it in maybe 15 or 20, because I was just going to basically say, everyone is human, everyone belongs. And as one of the community members said on public comment, and it's not a right, it's a need. But it hit me that, oh, well, no, actually, this is why my office is in existence. This is why the Office of Equity is in existence, because some people have been dehumanized and othered, and not to mention people who don't have money or are poor, and health access, equitable access for equitable access to health quality, let me back up, quality healthcare and healthy outcomes for all may or may not be of value for the nation or the state. And so now I do need to speak longer than 15 minutes because I was just basically going to say, just do it, make a decision, let's make this the goal of our system and make it happen. But listening to you all today, I'm thinking that perhaps I would like to offer up some things that might make us commissioners go, we've done some great work thus far, but is it the work that's really, really what the people need? Really, really what the people want? Or is it just good work that makes us feel good, that maintains the status quo? So you get to, we will get to decide. So the vision for the Washington State Office of Equity is that everyone in Washington has full access to the opportunity, power, resources that they need to flourish and achieve their full potential. Now, at some point, I'm going to see if I can make this advance. Okay, there we go. And how do I move this? So I don't want you to see that. Am I getting it right here? There we go. Yay. So in listening to thousands of state employees, thousands of community members, our first year when we were tasked with designing a 5-year statewide equity strategic plan, we asked the question, well, one, if indeed we are going to be an anti-racist, multicultural state, it was the desire of the governor, what would that look like? What would it feel like to live there? What, I don't know, opportunity gaps need to be bridged? Which inequities and disparities need to be eliminated? How are we going to measure that? And the second question for state employees, if indeed we're going to bring our A game to work each and every day and really center equity, right, to sustain workplace diversity, what's that going to look like? What's going to feel like to work there? Which opportunity gaps need to be bridged? Which inequities or disparities need to be eliminated? How are we going to measure that? Because we can't name it, we can't be it. And in listening to thousands, and I mean thousands of people across the state and even outside the state, to be honest, we came up with our pro-equity, anti-racism or PAIR plan and playbook, which basically is an ecosystem, acknowledging that we as humans, we as organizations do not exist in isolation of our earth systems, of other systems. And perhaps what's going on in the humans is impacting what's going on in nature. And we believe that if we really are going to be a multicultural, everybody has what they need to succeed kind of state, then we must have values that inform and serve as true north for all of our decisions and actions. Because without them, we maintain the status quo. And those values must inform then what we're calling our service lines, basically, bottom line, the DNA, how we do business, our policies, our laws, our procedures, our programs. The values inform those, so that we can begin to start helping change those conditions that impact people's lives. Health, transportation, economic justice, where we live, home ownership. You can see it here, education. We call these determinants of equity. And I have to just put a pause here. My background is in healthcare. I grew up as an occupational therapist, as worked in human resource or personnel back then in the Department of Veterans Affairs, and ended my career as an administrator of a VA hospital. So healthcare is I'm a systems thinker, and that's the lens that I come to this work, bring to this work. So in thinking about this equity strategic plan, of course, at the forefront of my mind were the social determinants of health, because those are conditions that impact people's lives. Yet I see in these determinants of equity, most of the social determinants of health are here. And so we're going with this work from King County. And we believe if we begin to really center and listen to people and help come up with ways that remove barriers, right, for people to thrive, then and only then will we be able to achieve our vision where everyone in Washington can flourish and achieve their full potential. And this work cannot be done in isolation of the people who we say we're here to serve. Community is the guiding light for all that we do. Otherwise, we are replicating what's referred to as a characteristic of white supremacy culture. You can Google the article, a patriarch or paternalism. And paternalism is when an organization believes that they know best what's best for the people that they are in existence to serve. So, and we heard this, oh my goodness, from far and wide. And so part of our strategy across the state is to make sure that it's nothing about us without us. It comes as a mantra from the disability justice community, meaning if you're going to come up with, in this case, healthcare for all, then maybe we might need some people who are impacted by our healthcare system at the table to help redesign the system. Any questions, just overview of how we're looking at this? So this is the work from the Office of Equity. And just unmute, or if somebody can help me, Mandy, if somebody has a question, let me know. So when I was thinking about health equity and what's that going to look like for all, and by the way, just for transparency, this for the most part was a presentation I put together last year for a different group, but I edited it for today's conversation on health equity. Health equity and anti-racism. I got this from, I don't even see the sources, so forgive me. But wherever this slide came from, the source indicates you can't really talk about, they're talking about children, but it's really health equity for all, without acknowledging the impact of racism on the health of communities, families, and children. And the reason why I'm bringing this up is because when we think about structural racism and the biases, we often think about slavery, Black people, white people. Yet I want to offer up for our consideration here today that system worked, chattel slavery, works so well for othering, in this case, Black people, that system has been used to other people, women, other people of color, people with disabilities. Yes, Aaron, do you have a question?
I do, and I appreciate you. I didn't expect you to give me the floor so quickly.
Well, make it quick.
My question has to do with social determinants of health and how in the US would we really have a system where it is a social determinant of health what coverage you have access to and can sign up for.
Yeah, you
and
will.
I just was one thing that wasn't mentioned, and I wondered what your thoughts were on that.
Hold that thought. Just, and if I don't come back to you, let me come back to you. Hold that thought. So we have to spend some time talking about structural racism and unconscious bias that leads to the disparities that we're now seeing. And I know many might be thinking, oh my God, here we go again. Do we talk about racism again? I'm tired of talking about racism. Well, imagine how people feel who are experiencing it, or any ism, really. You know, particularly since access to care is getting, people are dying. You know, since between 2018 and 2020, drug overdose death rates increased across all racial and ethnic groups, but increases were largest for Black and American Indian, Alaskan Native people. Well, I wonder why. I have a hypothesis. I believe that when the European colonizers came and thanked the American Indian people for getting them through that first winter by raping my foremothers and stealing our land and committing genocide, that might have led to some trauma, not to mention some trauma associated with being, I don't know, lynched, beaten, treated less than human, trauma. So there's a book entitled The Body Keeps Score, and this is generational trauma. And I would also submit that this trauma is not only for those who were oppressed, but it's also experienced by the oppressor. So racism, I believe, has caused harm to everyone. And this is why I believe it's time for us to be intentional to get healed, set free, and delivered so that we can move forward in reconciliation and transformation. And I'm not going to go through this slide, but this is just a snapshot of how in the US we have maintained a pretty much segregated racialized society. So when I use the term, I'm not saying anyone at the sound of my voice, including myself, is necessarily a racist. I am saying, though, that unless we are intentional about being pro-equity, anti-racist, we all grew up in this system that othered people. Because when you look at, for example, this slide, just with the Civil Rights Act of 1964, just shout out if you know the answer. When is White People Month? Anybody know? When is White Guy Day?
Every day.
Every day.
See, what month are we in? See, I've been on vacation so long, I don't know what month I'm in. So March was what? Women's History Month. What was February? Black History Month, right? American, what is it? Hispanic Heritage Month is September 15th to October. Anybody that has to have a month because they were listed in the Civil Rights Act of 1964 as amended in 1990 basically says, oh, well, they're not human. They don't have the rights of American citizens here. So we have to just set up a law not to discriminate against them. And so now we have a month or a day where the people feel as though they belong. Is everybody with me thus far? Are you catching this foundation?
Yeah, I'm straight.
Okay. You're straight. Okay, all right, you're straight. And so John Powell, who we had the pleasure of bringing to Washington for the governor's equity summit in November of last year, excuse me, is the executive director of the Othering and Belonging Institute in California. And he has this concept entitled the Circle of Human Concern. And he says in a democratic society, or any society really, people who have the right to enjoy the benefits that membership affords them simply by being a part of that society belong. Anyone who's excluded are oppressed by that dominant culture. In other words, if this were Dr. J then speaking, I would say each and every one of us on the planet belongs here and has value and worth and doesn't need a law to be told that we should have a right to health care or a job or a home or to live. We don't need that because we're already valuable simply because we exist. We're human. We belong here. And whether you're a Big Bang theorist or evolutionary person or God created you, however you got here, you didn't have any input into the earth suit that you're going to wear. Now, I probably would have chosen to be a lovely, tall, beautiful, chocolate brown queen of African, Blackfoot, Cherokee, Japanese, Jewish, Seminole descent. Probably would have chosen to wear this as my earth suit to navigate the earth, but nobody asked me. Kristen Peterson, anybody ask you what earth shirt you wanted to wear? Nope. How about you, Jane? Nope. Anybody? No. So how do we have the audacity to talk about who should be able to get their teeth fixed by a dentist? Who should have the audacity to determine who should be able to buy a home or educate their children? And so we now are dealt with, at least when I was in healthcare, what's called a pair of ACEs, adverse childhood experiences. And now with this work, there's adverse community environments, and you can see these life experiences, divorce, mental illness, incarceration, violence, these impact a person's resilience. Are you with me? And I don't know, I really probably should go off television. Just the killings in Memphis and yesterday in Louisville, and the devastation is incredible. I was leaving town. I live in Olympia, here on the ancestral lands of the Cowlitz, the Coast Salish, the Nisqually and Squaxin Island nations who stewarded this land and peoples for time immemorial, heading north on I-5 out of this land. And in Lacey, just the homelessness was beyond, there were no words. The tents, and it went on and on and on and on, just beyond words. and the discrimination that people are still feeling, and the emotional and the sexual abuse, where now women, if you're going to be raped, well, get prepared to keep the baby, unless, of course, our state and others can come together to do something about that. Healthcare, right? So all of these experiences impacts people's health. And I don't know if anybody still teaches Maslow's hierarchy of needs, but this is something I learned last century back in the day that seemed to be really relevant to this work. It was core and central, even in my work as a healthcare administrator, that we wanted to make sure that if we wanted people to self-actualize, to be their best self, to do you, be all that you could be, well, there are certain things that need to be in place, like esteem, love and belonging, safety and security, and psychological needs needed to be met. And as we can see, that in the US, communities of color, even people with disabilities, I would even say members of the LGBTQ community, still face a steeper climb to fulfill their basic needs because of othering. When we talk about the social determinants of health, I should have kept that slide and I took it out because I figured everyone knew. I apologize. So thank you for asking the question, Aaron. This diagram shows the different heights of the people, and they represent the unequal distribution of the social determinants of health in society, where people live, disability, socioeconomic status, sexual orientation, you know, all these unfair differences. And health inequities definitely have many implications, including costs, just the economic burden. It's projected to be 353 billion, and that's probably low. And just look at the mortality gap. It's widening, right? Opioid overdose, right? So Dr. King, who we celebrated his assassination 55 years ago on April 4th, he said of all forms of inequity, inequality really, injustice in healthcare is the most shocking and inhumane. Why? Does not everyone matter? Is not everyone human? We're going to have healthcare for all. And so when thinking about today, what I would like for us to think about moving forward is recognizing that the trauma is real for many reasons. And you know, by the way, I just want to call this out just for the record. I remember speaking with the chief of staff when I was at the VA Medical Center in Ann Arbor, and the University of Michigan was our med school. That's who we were in a relationship with. And this is right when we were beginning to see some Vietnam era veterans, because it was not declared a war. I don't know if it has been since I've left VA, but back then it was not they had not been declared a war. So Vietnam era veterans. And they were treated solely with drugs. And so I had a chat with the chief of staff, and I'm over with, I'm what you will call the COO now, talking to the head doc, letting him know that I didn't think that I was healthy. Well, with my occupational therapy background coming up, I'm like, that's not healthy. Let's give these guys an opportunity to succeed in life, because they weren't women, by the way. Why just medicate them? Just medicate them with drugs. How's that helping them? What kind of thanks is that for people who are willing to die for us? Well, I don't even know where we are now with, why don't we do some prevention? How can we prevent some of the illnesses that we're seeing? And I just want to offer up the drug use or abuse, the addictive behavior that we see. A lot of that is tied to the trauma that we talked about. Now, granted, we cannot blame what happened for our behavior now, but moving forward, we do need to recognize, instead of blaming the victim, blaming the person who's been oppressed, maybe perhaps thinking about what kind of healthcare we want to provide and pay for moving forward. dealing with the trauma in an equitable way so that people are resilient, because there is no resilience just taking a pill each and every day. If someone knows different than I'm all ears to continue my learning and growing, because I don't want to say the wrong thing. So what is health equity? And I'm not going to read all these to you. I'll just probably land on a box or two. You can take a few minutes, take a look at this. I'm going to start, and I just want to talk about this box. The route to achieving equity will not be accomplished through treating everyone equally. It will be achieved by treating everyone justly according to their circumstances. Now that sounds real good on the surface. How do we design a system that does that? And how do you even feel about that? Anybody, is there one person who has a thought that you'd like to share with us on that one? The route to achieving equity will not be accomplished through treating everyone equally. It will be achieved by treating everyone justly according to their circumstances. How's that landing? Anyone?
Dr. J.
Yes.
Yeah, completely agree. I ran, our healthcare program at my tribe. And to me, equity versus equality. Equality is like everybody gets an appendectomy, whether or not they need it. Equity is if you need an appendectomy, you get an appendectomy. If you need your gallbladder removed, that gets removed. It's looking at the people and providing the care that wraps around them, I think, is what I think of as equity.
No, thank you. Nicole Gomez.
Yeah, when I think about being treated justly, I also think about how treating people the way in which you wish to be treated, sort of like with a mutual respect. That's kind of how I think about it.
Mm-hmm. Okay. Thank you. So health equity is when all people, regardless of who they are, where they live, have the opportunity to live the longest and highest quality.
Dr. J, sorry to interrupt you, but I think Mohammed had a comment too.
Okay, Mohammed.
No, it was all covered. I just wanted to add meeting everybody's need where they are, because there's some people that cannot come to the table because of everything that's going on. So meeting everybody's needs where they are, and basically humanizing our needs and differences.
Exactly. And in this day of Zoom and all this, we have no excuse for not being able to do that at all. Thank you. Okay, so we talked about this one. So Mandy, so what's going to look like when we achieve health equity? What's it going to look like? Well, we in the Office of Equity believe that when we have successfully achieved health equity, then everyone will have the opportunity to reach their full potential without disadvantages stemming from social conditions. Everyone will be able to have the opportunity for a long, healthy life, and not barring stuff for which we don't have any control, but the barriers will be eliminated. For example, when that chief of staff I was telling you about in Ann Arbor was on vacation, his assistant chief of staff was acting in his place. He called me into his office one day. I'm thinking, don't these guys know I have work to do? What could possibly going on now? He called me because he wanted to apologize to me. I'm like, apologize for what? He apologized to me because he said when he was growing up as a surgeon, it was customary in their day to go ahead and give Black women hysterectomies, whether they needed them or not, to control the birth of Black babies. I was absolutely devastated. And he he held himself together. He didn't start crying. But he did ask me to, he said, now I can't do anything about this, about what I've done, because he performed many of those hysterectomies. However, he did ask me he wanted to pay it forward and asked me to promise him, excuse me, that if anyone ever told me that I needed a hysterectomy, especially at that time, that side of 30 or 40, to get a second opinion. I thought that was probably one of the most noble, humane things I've ever experienced in my life. But it also talked about the inequities that were built into the system. So in thinking about what we need to be thinking about, or what I ask many to think about as we do equity work, are just 4 simple things. 1, just increase some self-awareness. 2, begin to align your values with your actions. 3, begin to retrain your brain of what you think you know, what you believe about certain people, which may or may not be true, and begin to take deliberate, equitable action. So for example, Angela Davis says, we have to talk about liberating minds as well as liberating society. So increase self-awareness, make the unconscious conscious. Often you hear this spoken about in terms of like implicit bias. And again, you can Google this, but this is when we refer to unconscious stereotypes toward a group of people that affect our understanding, our actions, and our decisions. Whether or not it's true or not, it's often said that we don't really see people as they are, we see people as we are. And then when we go have a conversation with them, if they say things to us that are different than what we believe is true, now we're in a fight and an argument with the people when they're speaking their own truth. They can be positive, they can be negative, they can affect us without us even being consciously aware. For example, a person can unknowingly prefer one racial group to another without being a vocally and consciously racist individual. My hair is real. Many of you may not know about the Black woman holding the sign, my hair is real. Often people want to touch a Black woman's hair. Don't ever, ever ask to touch a Black woman's hair, or ask her if it's hers. She'll tell you, yes, it's mine. If I growed it, sewed it, glued it, bought it, weaved it, whatever, yes, it's mine. Someone who is, I am not a color, I will not cut your grass. Muslims are not all terrorists. I'll marry whoever I want. So I am not white trash. So many stereotypes have been given about people and could impact our decisions. The way they show up in healthcare are just a few here, many of which you're probably familiar with. Some you may not be. Okay. Again, this would be a barrier for access to equitable quality healthcare, as well as would impact outcomes for people for healthcare if our biases are in play. So I would invite everyone here to just jot this down. Just Google Harvard IAT, not now, but just jot it down. Harvard IAT, or take the project implicit test today. There's one on race, gender, just a whole host, people who are obese, women versus men. Many tests have been given by billions of people. Now, I do need to contact them, I have to admit, because I had someone who was blind, asked them to take the Harvard implicit association test and forgot. Well, first of all, forgot the person was blind, but forgot that you need to be able to see to take this test. So I will be reaching out to them for that. But go on, take a couple tests, because you won't even know where your biases are until you have an opportunity to learn some information about yourself. Because again, we've all been conditioned in this culture, and we cannot redesign a system with the same people who built it or for whom the system is built. This is why, for example, SATs, the Scholastic Aptitude Test, I don't know if they still give that to get into college, but back in the day, when they take the SATs, those were normed for white people. The only reason why I did well in the SAT is because I was educated in all white schools. But it wasn't, and this is why we ought to be concerned about artificial intelligence in this generation and who's running the all algorithms, because our biases impact those kinds of things. Like, for example, when we take a look at Black use of drugs and sale of drugs between Black and white people, who gets arrested and who doesn't get arrested, you can see inequities, right? Because until we make the unconscious conscious, it will continue to control our life or our system. We'll just call it fate. The second thing we want to do in terms of equity considerations is to align our core values and our actions. You know, if indeed we really believe and value health equity for all, well, how do we live it out? And that, I would think, would be one of the challenges that the community public comment voices are saying to us. How do we build that into this redesigned healthcare system? And I would offer up for our the commissioners, you know, what values then would we even need if we're going to seek universal healthcare for all? The third thing we want to do is retrain our brain. Alvin Toffler said, the illiterate of the 21st century are not those who cannot read or write, but those who cannot learn, unlearn, and relearn. And I am going to warn you that this next picture is graphic, but that was by design. Is it that all Black people need to be shot? This child, Breonna Taylor, she had just finished treating COVID patients, was home in her bed, in her own bed, and was killed. We all watched the murder of Mr. Floyd in broad daylight, right? Isn't that all Black people are criminals? When the data show us that unarmed Black men are shot at a greater rate than armed white guys. Nobody asked anybody who killed these people, do you want to go have lunch at Burger King? But they certainly asked this young man here if he wanted to go have lunch at Burger King. Who's this young man here at the lower right? Who's that? You know? Oops.
Dylan, the fellow who shot the folks in Charleston.
Exactly. Now, to the extent that we consider that behavior less than desirable, and this is a white face, the way one would retrain the brain is, and to the extent that we consider any of these Black men noble or honorable or whatever the word is good, and because typically we associate good with white, bad with Black. So to retrain the brain, you find some good Black, not good behavior white. This is not about good people or bad people, it's about behaviors. That's how one would retrain the brain. And in a different slide set deck, I have like just continual play images of Black men that are considered great achievers and contributors to society, juxtaposed with Dylan. Robin DiAngelo has written a book entitled Nice Racism. I would highly commend it all. You can Google a 21-day equity challenge. All of these are resources that would be very helpful. One of my favorites is entitled Me and White Supremacy. This is a journal, a lesson, reflection, journal, things to help us really talk about, right, social determinants of health. How are we going to really make an impact on healthy lives for all if these indeed are the social determinants of health? Aaron, now what was your question? Do you remember what you asked me?
I was asking about how health insurance coverage access, like what kind of coverage you are able to get enrolled in. I think is highly inequitable in the
Okay.
US.
Well, I think that's a question above my pay grade. However, perhaps it's not. We'll continue. Also, I did want to bring to everyone's attention the book entitled The Sum of Us by Heather McGee. She's a policy wonk and has done an outstanding. Oh, well, here we go, Aaron. Take a look at read this book. I'm not sure, I can't remember now. Heather talks about health in particular, but I know that she has some great insights about what it could look like. So just a few resources for you to consider, but The Sum of Us by Heather McGee is pretty incredible. And again, this slide, I know I must be close to time. Yes, it's basically saying, and commissioners, we're all in a different place in our journey. Some of us, we are unconsciously incompetent when it comes to health equity or racism or any of that stuff. We don't know, and we don't know that we don't know. Then we would become, and that's okay. That's a starting place. Oh my God, I had no idea. Consciously incompetent, I don't know, and now I know I don't know. That's a really good starting place. Oh my God, I had no idea that this is what I was believing. When we're unconsciously competent, things are going well, but we don't know why. You become consciously competent, we do know, and now we know that we know. And what we really want to do in terms of equity, just make it as natural as breathing air. Nobody's thinking right now, oh my God, I better inhale or I'm going to die. Oh my goodness, I must exhale or I'm going to pass out. No, you're breathing automatically. And we want to automatically begin to be equitable. But just know that it takes time to get here if we're not, I don't know, if it's not part of our daily living each and every day. Because it is a privilege to educate ourselves about racism instead of experiencing it. So Angela Davis said, in a racist society, it's not enough to be non-racist. We must be anti-racist. Well, what does that mean as it relates to redesigning our healthcare system? I brought Representative John Lewis's memory into this room because he's told us to never ever be afraid to make some noise and get into good necessary trouble. And so first off the bat, let's just fight to eliminate health disparities. I think that as we do our work, there's a plethora of data of where the health disparities are in our state. Let's begin to even start using that with, as Muhammad said, the voice of the people who are impacted. And as the person at public comment was talking about, those who are also in poverty, let's start bringing them to the table. To start talking about this. Now, I can't really talk about redesigning our system without bringing Dr. Deming to the table, because I was the protege of one of his proteges in Ann Arbor for not only redesigning a healthcare system, but how we even prepared leaders throughout the whole VA system, changing how we prepare them to lead. And the one or two thoughts from this slide that I would just like to offer up is his fundamental question is, what is the aim of the system? And so I think that's a question that we really must grapple with, commissioners. What's the aim of our commission? Is it affordable healthcare? Is it quality? Is it access? Is it outcomes? Is it people to have long, healthy life? What is the aim of our system? Because without an aim, there is no system. And we must really also admit that our system is perfectly designed to give us the results we're getting. Otherwise, we wouldn't be getting them. So let's just be clear. But the one that really, if I could just find it, about everybody winning. Oh, oops, darn it. It would be better if everyone would work together as a system with the aim for everybody to win. I don't know if I can't change this. I was trying to make it bigger. And this goes to your question, Aaron. If we had insurers, physicians, pharmaceutical companies, community coming together and everyone won, what would that look like? What would that look like? But we can only do that if indeed that is the aim of the system we're seeking to redesign. things that make you go, So I'm hoping you're really thinking, Dr. J, you make me think. Good, that's why I'm here. Because what did the woman say? The public comment, she said, healthcare is not a right, it's a need. Well, John Powell said belonging should be a right and not a privilege, meaning simply because we exist, we belong, and we are able to self-actualize. And when you look at our pair plan and playbook, our determinants of equity, our pair values, our vision, all of this right here in Maslow. And maybe we need to be elementary and just go back to Maslow and begin to design a healthcare system that does this. Things that make you go, And also in terms of when we're considering things for consideration, I just want to put out here, we have an opportunity to do some great. And the first wrong question is, what do we need to do? I'd like to offer up the first right question is, who do we need to become? Who do we need to become? And because people need to feel safe in a state of belonging. I belong here because I belong. And Washington needs to become a state in which everyone belongs. So right now we are working with the governor's office and John Powell to become the first belonging state in the nation, if a couple other states don't beat us. But nevertheless, we need people want to feel a state of belonging, especially when they go into healthcare systems. In the Department of Veterans Affairs, when I was a leader, there were not many women veterans, it's largely men, actually predominantly men, virtually all men. But the thing about men is they don't go to the hospital. And so when they showed up to our system, they had several system failures, endocrine, circulatory, respiratory systems, multiple system failures, which was a cost really to them, because that required more time that we needed to spend with a veteran, which took away time that we could spend with another veteran. So our marketing campaign, this is why you need women around. I'm like, well, go talk to the woman. Who's their woman? Is it the wife, the mother, the sister? Go get the woman to have these veterans come in. So we marketed to women to start bringing in men to our system. And the reason why I still believe that the Veterans Affairs system needs to remain that system is because there's something about veteranness that impacts their healing that is not experienced in other healthcare facilities. So what would that look like? I'm going to skip that. I'm going to skip that too, because the governor says that ambition and audacity is in our DNA in the state. Well, if indeed the arc of the moral universe is long and bends towards justice, which is true, what are we going to do to bend it so that there really is quality, accessible, affordable, whatever that means, healthcare for all? Simply because everyone has a right to a long and healthy life, simply because they exist. And we build a system that does that, that's win-win for all. Things that make you go, because a system must have an aim, and where there is no aim, there is no system. So that, I think that's pretty much all I wanted to just say today, offer up for consideration for today. $3.54. Okay, that's not too bad. I think I got you back on time.
Thank you, Dr. J. That was wonderful. I really
Things
appreciate
make you go,
Yep. Just laying it out there. I know you don't know how to be any other way.
No, my heart, it's my heart. My heart is hurting. because in this last week, it was convergence of Ramadan, Passover, Pesach. As a matter of fact, we're still in the middle of Passover. And the Holy Week for those who celebrate Easter of Christ. And I'm thinking, where's the love? Where is the love? And gas prices and food prices and I don't know, supply chain demand, whatever, just living now is, I'm not sure if we're exacerbating the mortality rate or not. And my heart hurts when I see people in the corner. I don't even have enough money not even give the people the money. Right? That's how many people are now in need. And it didn't used to be this way. I mean, sure, I'm sure my parents thought whatever, 50 cents for gas was a whole lot of money. I don't know. But there were wages, there was family, there was community that helped for the resilience. And if someone needed help, especially mental health help, they were put into an asylum. I don't know if they have those anymore. We kept them at home, or in our community, we just sent them down to the relatives down south. That's what we did, because we were first generation Northerners. The homestead was in the South. And then I just would just ask and hope that we could all just really think about who really belongs here. Who do we really believe that deserves a long and healthy life? Does everyone really deserve access to quality health care? To have equitable outcomes and not feel like if they go under surgery, the doctor's going to kill them because they don't like pick a group, any group, women, Black people, Hispanic people, I don't know, gay people, pick a group, any group. We want to make sure that we are in a system, I think, where there's trust and love and hope. And if we did some of that, maybe that would decrease the need, especially for all the mental health issues and people that I saw. As a matter of fact, I'm thinking, you know what? I need to know what the number two medications are, and have a doctor write me a prescription. Excuse me, so I can always have them on me to give the people the meds. Because I know when they run out, it's when they run out of money, because that's when they start manifesting. And then the next month, when they get their money, they're able to get their medications. They're able to show up with a sense of lucidity and peace. So help us to do better. Thank you for your time. I yield back the remaining of my time, or whatever time I have.
Thank you so much. It's very grounding to remind us the discussion is greater than just benefits and cost sharing. Thank you. We are going to set aside the conversation about transitional solutions till next meeting, but I don't know, John, can you do ERISA in 2 minutes?
I think we can start the conversation, and I have the unenviable task of speaking after Dr. J. Thank you so much for your comments. So very quickly, just to kind of remind folks where we are, we're going to start the conversations about ERISA and where ERISA fits within a universal healthcare system, and as a starting place for FTAC. I think we'd really love to get a sense from the commissioners what questions and what starting point would you like for FTAC to consider, right? So really, essentially, just in the same way that they considered eligibility questions related to Medicare, what options are the commissioners particularly interested in having the FTAC kind of assess and discuss, and then bring back some recommendations on. And we'll continue this conversation in the next meeting but just to get an initial sense from commissioners.
Okay, so I have some thoughts. Dr. J, when you were talking about sort of what the aim of the system is and why we're here, I started thinking about what can we meaningfully impact, right? So limited resources, limited time, where do we devote our energy to get the greatest benefit to the greatest number of people? And for those of you who don't know me, I've been doing ERISA analysis and following ERISA case law for over 30 years. I started working on it back when the legislature did the Health Services Act back in 1993. And when I think about the time and the resources that we have, and when I think about the really good memo that Erin Fusé-Brown did for the Oregon Health Commission, my recommendation in terms of the questions that we would have FTAC answer is, rather than focusing on, can we get a waiver from Congress? Can we get a massive waiver from HHS? But to instead focus on two aspects of ERISA. We have, and I think this is sort of similar to where Erin came out with respect to what she shared with the Oregon Commission, which is, you could look at a pay or play system where essentially you're saying to an employer, you have a choice. You can provide coverage to your employees, or you could pay into our universal system and have your employees go into that system. And alternatively, which I think is what Oregon came up with, you can say, we're going to ask every employer, because it's going to be a payroll tax-based system, to pay into the system. And at some point, it becomes financially infeasible for you to both pay into the system and also pay for full coverage for your employees. The pay or play concept was actually upheld by the Ninth Circuit in a city of San Francisco ordinance case back in the 1990s. And I haven't shepherdized that case in a long time, but I don't think it's ever been like flatly overruled or reversed. So my recommendation, bottom line, is that we ask the FTAC to look at what's within the realm of the possible. And then the other premise that I have undergirding that is, our job is to build and design a healthcare system that will be so appealing to employers who have self-funded health plans that they want to have their folks enrolled in this system. And whether you do it a pay or play version, which is a little bit more draconian, or whether you do sort of the suggestion to Oregon, or whether you just say, we're going to go ahead and design this system, we're not going to force employers to do anything, but our job is to have the system function so well that your employees in collective bargaining, or in whatever your efforts are to try to keep your employees, say, I want that. And I mean, one tiny example I can give of this is, we knew when we passed our state balanced billing protection law that we could not mandate that self-funded employers come into our system. But yet, because we were providing protections that their employees didn't have, we had over 350 employer health plans representing 500,000 lives opt in to our state law, to willingly say, I am willing to have the state regulate this aspect of my plan because it's important enough to my employees to give them these protections. So that is my thought on that question. Sorry if I talked for too long.
Jane, do you mind if I just ask a clarifying question? And Badisha, I'm sorry, I see your hand up. Are you motioning to exclude anything? I just want to clarify. It sounds like
yeah,
or
I am
motioning to limit some, or motioning for two items for discussion.
Yeah, I am proposing that we not look at getting a congressional waiver or federal waiver. And I am proposing that we not mandate that self-funded group health plans participate in this system. That there has to be an element of choice. And the question is, the question is, how do you structure the choice that could pass an ERISA litmus test? With the freest choice being, we're going to do with the best that we can to build the best system that we can, and y'all come if you'd like to. So
Do you also want, are you also, just clarifying, sorry, Jane, are you also saying the other option too, the pay or play option should be investigated by FTAC?
yeah, it's probably worth it to look at it just to update the case law on that. And I think, and Erin, I think, had something, she talked about pay or play in her memo also. So, and I felt perfectly comfortable with the legal analysis that was in Erin's memo. So I would be perfectly comfortable having the FTAC rely on that legal analysis.
So there's a motion?
Yes. Do you want me to do a motion?
No. I think you did a motion just fine. I was trying to hint for a second. Sorry. Is there a second? Sorry, Vicky, I didn't mean to jump in, but I just wanted to clarify whether it was a motion, and I'm so sorry. I just wanted to check.
Is there a second? And then we'll continue conversation.
This is a large motion without having any public input, and you're taking a vote on it already. Seems not appropriate.
Okay, well, is there a commissioner that has a comment?
This is Dave. I often agree with Jane, and I'm not saying I disagree with Jane. I do worry about us moving to kind of a formal motion so late when we started the conversation 2 minutes before the public meeting was supposed to end. I like being able to frame it, and how we opened with John saying we're going to start the conversation. I think Jane has a lot there. I wouldn't be ready to quite second a motion quite yet. Sorry,
Would
Jane.
it be helpful if, and I'm going to let the vote continue, but I just have a quick turn on that in light of your comments. We could take the first two questions to FTAC so that it's available in their next meeting if they have time, and so that's available for their discussions, the two that Jane highlighted, and we can leave the remainder off the table for now. We just take questions, because I think there's enough right now in the two questions that Jane mentioned for their work to continue through the work plan until our next meeting at the commission.
Yeah, I'm sorry, I'm not sure if I'm being called on or not, but I would just say I think it's great to continue that conversation. The part that gives me hesitancy is the exclusion of other aspects being on the table. I would love for the FTAC, personally, I'd love for FTAC to look at the questions Jane proposed. I'm just not comfortable sitting here at 4:08 to say to the exclusion of other things.
Understand. I'm sorry, I meant we could, in the alternative, table that particular topic for our next discussion at the commission, the exclusion issue, and we have enough matter from the first two top questions that Jane developed for FTAC in the meantime. If that doesn't work for everybody, I'm sorry, Vicky, I will jump out and let the voting for amendments happen as they want. I just wanted to address Dave's particular concern and let commission members think about that.
Batisha, did you want to go ahead?
Yeah, I wasn't sure whether I should lower my hand or not because I had an initial question, and but just pertaining to what Jane brought up, I think that I would like to not vote on the motion right now and learn more about ERISA, because Jane has a background where she knows a lot, and I have read the Brown and McCuskey report, but it's still a lot of questions for me. So I just think that I would like, it might be better that we bring our questions to FTAC now, they answer these initial rounds, and then we go back to Jane's motion. And then I also have another question, and I can ask that later.
Is it?
Or
It's
if you want
different.
me to, I can.
Go ahead and why don't you just put it out there while you got the phone.
Okay, so my question was regarding this, what questions would commission like to have ethic answer regarding ERSA? And my, what I would really like to see is actual numbers. So I think the reason we are discussing ERSA is to figure out a way to avoid the preemption and be able to capture the employer contributions that will fund that single payer system. And I think it's time that we start looking at those dollar values. So I would really like to see those numbers for the state of Washington, that if, there are many different states are trying to, they are looking at the single payer system, and there is the payroll tax, there is provider restrictions, there is pay or play, there are different types of plans. And I would like to see the numbers corresponding to each one of them so that I have a sense of, how will the single payer system be funded? And if, as Jean brought up, that, it's your choice, that also means that, that dollar value it's varying. It's not guaranteed. So I would like to have that understanding. So that's my question for FTAC, that give me some numbers.
Thank you. Pam, did you have something to add?
Yeah, I hope so. That this is some value. I think I said this at the last meeting too, when we were talking about Medicare. So it's very much in the same spirit, that these questions are so big, and there are so many ways you can go after them, that the guidance is really super helpful to FTAC. So the way that Jane framed it, I liked. I also liked how Dave modified it to not say, this is our conclusion, do you agree with our conclusion, but just as maybe more that this is a hypothesis, or this is a way we think we can frame this issue. Feel free to add on if you want, but really let's pressure test it at FTAC and then come back. I think that's a really good way to use FTAC. So that's all I wanted to add.
Thank you, Pam. Jill?
Hi all. Sorry, it took me a minute there. I was going to say the piece that I also really appreciated somewhere between Jane and Dave's comments were around, it's such an area of law that has continued to evolve, where there have been cases that have put some more discrete bounds around what is possible, at least in the immediate legal environment. So I would appreciate, I don't know, Mandy, in figuring out the right scope of the FTAC, John, I'm sort of curious about whether or not just an initial recommendation around back to us around, here are areas of very law that are unchanged since the last analysis that was done on this topic, which Jane was referencing, versus here in the discrete areas that Jane identified that might be of interest. Here's some new developments that, just as a way of trying to narrow us down to, what's settled and we've already looked at before as a state, where there are potential sort of areas of wiggle or in between that I think Jane was sort of driving to in some of her questions as well. So that is not a clear motion, but it's sort of, I'm somewhere in between the narrow the scope of the initial field with a focus on not retreading the good work that was done on this just a number of years ago. Like, where is there a value add in digging in and looking at maybe new things or new arguments or new approaches versus the same kind of brick wall that we've all been running up against for several years now.
Thank you. So, Mohammed?
Thank you. I just wanted to put it out there. I have had a chance to take a look at the Senator Hasagawa and Cleveland's bill, and it actually offers a lot of potential solutions. So I was wondering if we can have FTAC actually study the bill and see if we can pull some really helpful solutions there, instead of spending more time on something else than get to the point. I think it's worth considering.
I didn't realize I was still muted. I know we already took a vote on instructing the consultants to kind of work that into our plan. So I don't know how people feel about having FTAC. I mean, as part of our plan, we can definitely send different parts of it to FTAC, but I feel like you're saying just the whole overall bill and picking and having them give us advice back on what they think fits with what we're doing. Is that a good summary, Mohammed?
It is, yeah, and thank you. And I forgot to actually add about Oregon as well. They have a similar process, and I know we're 2 different states, but there's so much we can learn there, that can help us not to reinvent the wheel, save some time there as well. So I don't know how we can manage taking some helpful information from both Oregon and the bill, and then maybe that would help shorten the process for us. I don't know. I'm just brainstorming.
No, thank you. I think we're gonna need to continue our conversation at the next meeting, but I think we have a need to make sure that the FTAC doesn't run out of, and I don't think they will, things to talk about. But does that sound fair, John, Mandy?
I think we've got plenty of materials here
So-
from ideas from commission members that we can look into, and I really appreciate everybody putting time into giving us some guidance so that we can help give them some preliminary information and questions for the guidance back to the commission.
Yeah, and just to clarify, the motion never got a second, so it goes nowhere right now, but this gives us time to think about it. If you get a chance to attend the FTAC meeting, there's a recording of it. It goes on the website too.
It's on the website,
So
yeah.
that might help commission members too, to kind of listen. And it's fascinating. There people with a lot of knowledge. Even I know everybody here has a lot of great knowledge too. So I think we can wrap this up for now and know that we will continue this conversation. The FTAC will work on their the topic, the Medicare topic, and I think there's enough in here to kind of get them going on ERISA. Is that right, Mandy? Am I understanding that? Yeah.
We're set. Thank you, Vicki. And thank you.
Thank you. And thank you. This has been quite a meeting with the Zoom bombing that we need to do something about. Sorry about that. Dr. J, thank you so much for your wonderful presentation. You always hit me right in the heart, and I really appreciate you sharing everything with us and really reminding us that this is about, the equity piece is as important, if not more important than the rest of it. That, there's systems in place that keep people from getting what they need, and we need to address that. So I think we're at the end of the slides too, John, right? Is this the last one? Oh, next steps.
Yeah. Next steps, and we've already gone through this, so I don't have to belabor it. But essentially, we'll have the next FTAC meeting, which will take up some of these topics, as well as certainly the Medicare topics, and then we will be back in June.
All right, June 13th, 2 p.m. And then for the public who weren't able to get their comments in during the time allotted, my apologies, please use the email address in the chat box to send those written comments to us. It's important that we hear from the public too as we do this work. So I just want to thank everybody for staying over for almost 20 minutes and just for all the work that you do and the time that you volunteer to help support this work, and to the staff and the consultants for all the work they do in the background that you guys don't see, but it makes this all work out. So thank you all very much. Have a great evening.
Thanks, Vicki. We love you.